Good morning, everyone. Thanks for coming to Grand Rounds today. And I will turn it over to Kat to introduce our speaker.
Good morning, everyone. We're very happy today to welcome you all to virtual Grand Rounds. And this morning, we're extremely fortunate to be hearing from Dr. Mandip Dhamoon. Dr. Dhamoon earned his medical degree here at Mount Sinai School of Medicine, followed by an internship at Jacobi Medical. He then transitioned to Columbia University, where he completed a residency in neurology, fellowship in cerebrovascular disease and neuroepidemiology, and earned a doctorate of public health in epidemiology from the Mailman School of Public Health. He now serves on the faculty of the Department of Neurology here at Mount Sinai as an associate professor. In addition to a very busy clinical practice as a vascular neurologist, Dr. Dhamoon is a dedicated educator of trainees of all levels and serves as the director of the Stroke Fellowship Program. He's also a widely published researcher with a particular interest in disparities in care of acute stroke and long-term and cognitive outcomes of cerebrovascular disease. A very warm welcome this morning to Dr. Mandip Dhamoon.
Thank you so much. I really appreciate that and appreciate the invitation as well. The topic of today's talk is the cognitive and functional outcomes of stroke and cerebrovascular disease. And I chose this topic because it's not just of interest to neurologists, but since stroke is so common and its cognitive and functional outcomes last for so long, it's of interest also to more of a general medical audience. If there are any audio or video issues at any point, please just let me know. I don't have any disclosures. So this is a very exciting time in stroke treatment. So if you know, in 2015, mechanical thrombectomy was proven to be very effective for the treatment of what we call large vessel occlusion strokes, which is a subset of acute ischemic stroke. So this kind of case is becoming more and more common, where we have a 65-year-old male with atrial fibrillation, but not an anticoagulation, hypertension, who at baseline is fully functional and presents with acute left-sided weakness and neglect. It's found very quickly to have a right middle cerebral artery occlusion on imaging, is eligible in terms of the time window for IV thrombolysis with alteplase, and also eligible for endovascular treatment, which he would receive. And then within 24 hours, he would have marked improvement and even be able to walk out of the hospital. So because of these new interventions, this is becoming more and more common, but still it's probably available only to a minority of stroke patients. So much more commonly, this is the kind of stroke patient we see. The same kind of presentation, 65-year-old male, AFib, not an anticoagulation, hypertension, fully functional, but presents again with left-sided weakness, but after quite a bit of delay, 10 hours later. So outside of the window for any acute treatment. And this patient is found to have a right basal ganglia, so subcortical infarct in the brain. And if we follow the course of this patient in terms of his functional status, what we see, if we just plot functional status, higher being better function over time, before the stroke, there would be a slight decline in functional status just from the results of aging. Then at the time of the stroke, there'd be a sudden drop in functional status due to the deficits from the stroke. And then there would be a period of recovery, which I'll talk about in a minute. And then what we're seeing with more recent research, which I'll cover in this talk, is that there's a progressive functional and cognitive decline that we often see after recovery from stroke. And this is even in the absence of recurrent clinical events like stroke or even cardiac events. The reasons for this decline are currently uncertain, and there are no specific treatments for this decline. And this topic of delayed decline after recovery from a single stroke is what I'll be focusing on in this talk. So I'll first go over the traditional view of the relationship between stroke and disability and cognitive impairment. I'll cover what is known currently about the patterns of this delayed decline that I mentioned. Then I'll talk about possible mechanisms of this decline and open research questions. And I'll talk about each of these 5 possible mechanisms in turn. And then I'll speak about the current state of knowledge and future directions. So let's start in a basic way by first thinking about how we can conceive of the burden of stroke. So one way to measure the burden of stroke is fatality or mortality, so death, so measuring death. So if we have 3 patients, we can follow them over time, and at a certain point, we can measure their date of death. And so we can sort of mark that if we're doing a clinical study, and if at the end of the period of observation, they have not died or had another event, then they're censored at that point. We can also conceive of the burden of stroke in terms of events or recurrent events or related events. So say if they have a stroke at a certain time point, they may have a recurrent stroke later in time, and they may have a myocardial infarction at another point. So that can be measured, discrete events. Another way to conceive of the burden of stroke is to think of the disability or functional status. And there are a few ways to approach this. One is as an unadjusted measure, or in a way to estimate the effect of disability on the patient's life. So one example of the latter is the Global Burden of Disease study, which uses disability-adjusted life years to estimate the effect of disability on the population related to cerebrovascular disease and other diseases. So the DALY, or disability-adjusted life years, incorporates the years lived with disability as well as the years of life lost. So with that as a brief background, I just want to first think about what the traditional understanding of stroke is. So traditionally, we understand stroke as a discrete event. Out of the blue, there's a sudden deficit, and then that patient is left with that deficit. So if you think about the pathophysiology of ischemic stroke, what happens is that, again, just looking at functional status over time, there may be a slight decline in functional status due to the results of aging before the stroke. And then there's a sudden event in the brain, a blockage of an artery, a certain part of the brain dies. Related to what part of the brain that is, you may have very specific deficits. And those deficits cause a sudden drop in functional status at the time of stroke. And this drop is followed, if the patient survives, of course, in most cases by a period of recovery. And that period of recovery can take, as short as even a few days or a few weeks, but generally we think of it in terms of a 3 to 6 month period. And then, according to the traditional view, the idea is that, and the traditional thinking was that, the same slope of decline would resume at this new point of functional status. So now I'll just speak for a minute about this period of spontaneous recovery, and think about it in terms of impairment. So some research has shown that even in the case of irreversible damage to the cortical spinal tract, that's the major tract that controls motor function in the brain. So even in terms of, in the setting of irreversible damage, most patients recover about 70% of their initial impairment. And it's not exactly known how that happens, but there are several posited mechanisms. So one is that the edema surrounding the stroke may reduce over time, and that's why you have this delay, this recovery over a period of weeks or months. You may have regrowth of damaged neurons. You may have structural changes in axons, dendrites, so the supporting structures around the neurons as well, in terms of the matrix, the glia, angiogenesis. You may have changes in the excitability of the brain, and you may have changes also in the cell cycle proteins and growth factors in the brain. Also, there's some evidence that you may have some increased neural activity in other areas of the brain that are not damaged by the stroke. So either on the other side of the brain or in supplementary brain regions. And there's some evidence with transcranial magnetic stimulation to support this hypothesis. So that's in terms of the actual impairment. So if you have a weakness, you may have some improvement in the weakness. But even if you have, let's say you have a stroke that causes right arm weakness and you're right-handed. So you may develop compensatory strategies. You may learn to use your non-dominant left side to brush your teeth or to write or do other such activities. Or you may learn to use a cane or a walker if you can't walk after a stroke. And that is responsible for that improvement over a few weeks or months that we see, because it takes some time to learn these strategies. So that's a very brief summary of this very interesting area of this spontaneous recovery. But actually, the focus of my research and the research I'll be speaking about here is on looking at the trajectory of these measures before and after this period of recovery. And there've been several advances in the epidemiology of post-stroke decline to allow us to look at these time windows. So one is the expansion of the timeline of these studies. And another advance is the focus on patient-centered outcomes. So measuring patient-centered outcomes and not just discrete events in studies. So outcomes such as functional status, quality of life, cognition. And there's been a long history of understanding that stroke and vascular disease affects cognitive function. And this statement from 2011 published in Stroke defined vascular cognitive impairment in terms of very complex multi-part system. And even then there was recognized that there is pathologic overlap and similarity with Alzheimer's disease. The traditional view of vascular cognitive impairment was of a multi-infarct dementia. And this is probably still taught in the medical schools where you have sort of this sort of steady state in function, then you have a sudden drop followed by another steady state in function, followed by another drop. And what defines these drops are discrete events. But as I'll show you, the truth is a little more complicated than that. So another advance in the epidemiology of post-stroke decline is a shift of focus from measuring discrete events to measuring repeated outcomes, such as functional status. And what this has allowed us to do is analyze trajectories of these functional measures or other measures over time. And what this has allowed us to do is to begin to reveal the pathophysiology of vascular dysfunction and its effect on the population. So over the next few slides, I'm going to go over a few studies within this area. And the first one looks at the effect of vascular risk factors on this slope of decline over time. And the hypothesis was that with vascular risk factors, the slope of decline would be steeper. So this study we performed in the North Manhattan study, which is a prospective population-based study of stroke-free individuals, followed at the time of the analysis for a median of 11 years. So patients had to be at least 40 years of age to be enrolled and had to reside in North Manhattan for at least 3 months in a household with a telephone. So this was at a time, it's hard to remember this, but when landlines were a reliable way to identify patients. So patients were recruited in the 1990s. So we used models that we censored for the occurrence of stroke and MI occurring during follow-up. So patients were enrolled free of stroke and were followed with yearly measures of functional status. And the measure we used in this study was the Barthel Index, which is a score from 0 to 100, measuring activities of daily living. So if a patient had a stroke or MI occurring during follow-up, their measurements of functional status were censored from that time on. So the purpose was really to just estimate the effect of vascular risk factors in the absence of discrete clinical events. So what we found was that overall, there was an annual decline on this 100-point scale of about 1.4 points per year. And a few factors were associated with an additional annual change or decline in the Barthel Index, including especially diabetes, a very strong vascular risk factor. And this was in a fully adjusted model. So we found about a 1% mean decline over time due to the results of aging that was steeper in the presence of diabetes. Next, we wanted to see how this interacted with actual stroke events. So the traditional view, as I mentioned before, was that the slope of decline before a stroke would resume after recovery from stroke. But what we hypothesized was that there was actually an ongoing decline, so the slope would be different pre and post-stroke. So when we first started analyzing this, we looked at a stroke cohort. So we didn't have actually this data before the stroke. but I'll mention it because of the findings that we had. So this was another study within the Northern Manhattan population-based study. So this was a study enrolling incident ischemic strokes diagnosed within the 1990s and with otherwise similar criteria to the main Northern Manhattan study. We used a modeling strategy, GEE, or Generalized Estimating Equations models that accounted for repeated measures of functional status over time. And we estimated odds ratios and confidence intervals for a favorable versus unfavorable functional status, which we defined as favorable being basically full recovery, a score of 95 or 100 versus less than that. And similar to the prior analysis, we adjusted for demographics and medical risk factors. So patients in this case were enrolled at the time of stroke and were followed up yearly with measures of functional status. And as before, we censored follow-up at the time of, well, certainly death, but also recurrent stroke and MI, because our focus was what the effect was of a single stroke. So if a patient had a recurrent stroke, we thought that pretty straightforwardly they would have a decline in their functional status. The other point of this analysis is that we ignored the 6 months immediately post-stroke because that's known to be a sort of recovery period after stroke. So for all of these analyses, the 6 months after stroke we didn't incorporate any functional measures during that time because we know that there would be variability and improvement just as a result of the spontaneous recovery that I mentioned before. So what we found was that after stroke, there's a decline of in the odds of being fully recovered, and in a fully adjusted model, and this is even incorporating for characteristics of the stroke itself, there's a decline with an odds ratio of 0.91 per year. We performed a similar analysis in the Northern Manhattan study, looking at the outcome of quality of life. So, of course, it's different than functional status, and in fact involves a few other domains of self-reported health. And it's very valuable as a self-reported measure of health. And what we found was that quality of life declined annually up to 5 years after stroke. And this decline was seen only in those with Medicaid or no insurance, which we took as a proxy of socioeconomic status. And quality of life was also associated with age, mood, stroke severity, urinary continence, the site of stroke, and baseline functional status. So, so we found, again, that there's a decline after stroke in functional status and quality of life. Then we decided to look at a particular subset of acute ischemic stroke. So acute ischemic stroke is a very heterogeneous condition where you have several subtypes. So one subtype is lacunar stroke or small vessel stroke, which is comprises about 1 out of 4 ischemic strokes, depending on the population. And there was, at this point, a relative lack of data on this subtype of milder strokes. So for this analysis, we turned to the Secondary Prevention of Small Subcortical Strokes trial, which was a multi-center clinical trial, but because the main outcome was null in this trial, it was a very effective, large database for lacunar strokes with long-term follow-up. So for this analysis, we modeled not functional status, but its inverse. So the graphs will look inverted. So we modeled disability. So higher levels of disability connote, of course, worse outcomes. So patients were enrolled at the time of lacunar stroke. This first 6 months were ignored, and patients were followed up for a mean of 3.5 years. And what we found with that was that several factors were associated with a shift of the curve downward. So male sex, regular alcohol use, and a cognitive screening score at baseline. And several factors were associated with a shift of the curve up. So in other words, higher disability, including vascular risk factors such as diabetes and smoking, as well as prior stroke and depression. And a few factors were associated with actually a change of the slope. So a steeper slope of change over time, including higher age And this being a multi-center study, for some reason, there was some signal with the Latin American centers, which I'm not too sure what to make of that, to be honest, but that was also a factor. We did a similar analysis with the outcome of quality of life, and we found that several factors were associated with steeper decline in quality of life over time, including age, baseline educational status, prior stroke, and baseline functional status measured by the Barthel score. So I think these were useful analyses in terms of analyzing predictors of decline post-stroke, but they didn't really answer the question of whether the slope was different pre and post-stroke. So the next few studies were able to do that. So in the first one, this was in the North Manhattan study as well. So patients were enrolled free of stroke, were followed up over time for up to 10, even 15 years in some cases, with annual measurements of functional status. And over time, a number of patients had an ischemic stroke. So out of those 235 ischemic stroke patients, 210 had at least one follow-up functional assessment with the Barthel index. So we were able to, among these 210 patients, to model their slope of functional status before their stroke, as well as after recovery from stroke. So what we found was, in a model that accounted for confounders of functional status, we found that before stroke, among those with Medicaid or no insurance, there was a slight decline in functional status of about a half a point per year on, again, a 100-point scale. Then there's a particular decline at the time of stroke, and incorporated in this is the 6 months after stroke, which I just, for simplicity, just collapse into the line. But after recovery from stroke, we found that the slope of decline was steeper. So almost 2 points per year. And this was in the absence of recurrent clinical events, which we censored. A similar analysis was done in the Health and Retirement Survey. And this particular paper focused on race and ethnic differences in these trajectories. And so I'll just lead you through these figures here for a minute. So on the left are the trajectories among Blacks, on the right among whites, and there are three lines that you see. The solid black line is the estimated trajectory among those who do not have a stroke during follow-up at all. The dotted line is the trajectory among those who die of stroke. So that's estimated by this sort of this vertical gray line in the middle. So their trajectory, as you can see, just stops at that point, and they don't live past that point. And the dashed line is the trajectory among stroke survivors. So those who survive their stroke and have some measurements of function after that point. So the results were that among Blacks, there was a larger difference in independence between the stroke-free individuals and stroke survivors just prior to stroke. So the difference between this line and the dashed line was higher among Blacks compared to whites. And this difference, as you can see, was emerging even before the stroke. There's another analysis in the Health and Retirement Survey where they were also able to link to Medicare data on inpatient and outpatient medical services. So patients were identified in this case by hospitalization with a principal diagnosis of MI or stroke, and patients were followed with a combined functional scale incorporating ADLs, so activities of daily living, as well as instrumental ADLs. And there were 450 MI hospitalizations and 432 stroke hospitalizations. So what these researchers found was that in terms of looking at limitations, so corollary to disability, so as you can see, the curve slope upwards, with higher values being worse in terms of outcomes. So we see that after MI, there is a mean of 0.4 additional limitations just due to the MI itself. And after stroke, as you might expect, there were more limitations, on average 2. Then the researchers looked at changes of slope pre and post event. And they stratified based on baseline impairment status. So there's 3 lines here. So they found that there was a difference in trajectory slopes pre to post event for both MI and stroke if you look at the black line. So among those without any baseline impairment, you see that the difference between the slope before the event and after the event was significantly different. Similarly, there was a difference in the slope pre and post event among those with moderate to severe impairment at baseline. But the slope goes in the opposite direction. Probably what we're seeing here is a ceiling effect of the measurements, where you just are not able to capture any more impairments because that's just the limit of what the scale is measuring. And among those with mild to moderate impairments in baseline, there was no change in the slope pre and post event for both stroke and MI. We performed a study with a similar design in the Cardiovascular Health Study, which is a large epidemiological study. Patients were recruited from sex and age stratified random samples of Medicare eligible individuals from 4 states. One had to be at least 65 years of age, not institutionalized, and expected to reside in the area for at least 3 years, and of course able to provide consent. The original sample recruited in the late 90s was enriched with a sample of African American men and women a few years later with the same eligibility criteria for a combined cohort of almost 6,000 patients. There's very rich baseline extraction of information from multiple sources, and patients were again followed up over many years with annual measurements of disability, with, in this case, a combined scale of ADLs and IADLs. So this we analyze as continuous variable with higher values signifying worse disability. And we used, again, GEE models, incorporating repeated measures over time. And as before, we censored recurrent events. So there are 2 main cohorts in this analysis. Stroke cohort of 382 patients who had sufficient measures of functional status before and after recovery from stroke, as well as MI. So the MI cohort was 395 patients. So the demographics of CHS pretty much match the average demographics in the US, as you can see here. Hypertension and diabetes were very common, as you can imagine, in this elderly cohort, as was arthritis, a very common confounder of functional status and measurements of functional status. So when we first examined the average acute change in disability at the time of the event, for stroke, we found that there is an increase at the time of stroke of about almost 1 point on this scale of disability. At the time of MI, there was a significant increase in disability, but to a smaller degree, as you might expect. Next, when we examined change in slope pre and post event for both stroke and MI, we found that there was a slight increase in disability before stroke due to the results of aging, we presume. But after recovery from stroke, this increase was much steeper and higher over time. Whereas for MI, a similar vascular event, but not involving the brain, we found that there was no difference in slope pre and post event. And this was in a model that adjusted for confounders of functional status. The REGARD study is a large epidemiological study looking at disparities in stroke outcome and a very large population of over 23,000 participants. For this particular analysis, patients were enrolled without baseline cognitive impairment in the 2000s, early 2000s, and were followed up for a median of 6.1 years. The stroke cohort consisted of 515 participants, and they compared that to those who remained stroke-free. So the outcome was, well, they had several cognitive outcomes. One was global cognition, change in new learning, verbal memory, executive functioning. So a very rich assessment of cognitive outcomes. What they found was that stroke was associated with an acute decline in global cognition, new learning, and verbal memory. And among survivors of stroke, there was a significantly faster post-stroke rate of incident cognitive impairment. Next, we examined the effect of inflammatory biomarkers on stroke and mortality. And I'll go into why in a few slides, but in short, inflammatory markers and inflammation has been shown to have detrimental effects on events and vascular events, but we thought that it may have detrimental effects on functional status, even beyond these discrete events. So we examined 3 inflammatory biomarkers that were measured at baseline in the study. So CRP, or C-reactive protein, lipoprotein-associated phospholipase A2 activity, or LPPLA2, and tumor necrosis factor receptor 1, or TNFR1. And what we found in a model that adjusted for stroke and MI occurring during follow-up, we found that higher levels of CRP were associated with a shift of the entire curve downward. So not a change in slope, but really a shift of the entire curve of functional status downward. And similarly for LPPLA2, we found a shift downward with higher levels of LPPLA2 measured at baseline. And for TNFR1, we found not only a shift of the curve downward, but also a steeper slope of decline over time. In another NOMAS sub-study, so this was an MRI sub-study of NOMAS, where patients received an MRI at baseline of the study. We examined 2 major predictors. One was subclinical brain infarcts, which I'll speak about in some more detail in a minute, and white matter hyperintensity volume adjusted for total cranial volume. So the idea here was that these are measures of ischemic damage to the brain, but they're not overtly clinical as a clinical stroke may be. So what we found was that in a model, again, adjusting and censoring for stroke and MI occurring during follow-up, we found that there was a slight decline in functional status over time, but in the presence of subclinical brain infarcts, this slope was much steeper, almost double. And similarly for white matter hyperintensity volume. So when we incorporated baseline cognitive function, we found a very interesting result. We found that if we just take patients with a mini-mental score of 25 at baseline, no prior clinical stroke events, if we scanned them and did not see a subclinical infarct, their slope of functional decline would be about 1 point per 100 per year. But if they had at least even 1 subclinical infarct, their slope of decline was 50% greater. Next, we looked at those who had a mini-mental score of 30. So in other words, no cognitive deficits based on this measure at least at baseline. We found that among those without any subclinical infarcts, the slope was about 0.66 points per year. And this was almost triple the decline if they did have a subclinical infarct, but again, had no cognitive deficits at baseline. We also performed an analysis looking at the specific regions of the white matter hyperintensities in the brain, not just the overall volume. And without getting too much into detail, we found that particular regions of the brain, if they had greater volumes of white matter disease, they were particularly associated with functional decline, as well as asymmetry, left and right asymmetry. So if there's greater predominance of white matter disease on the right side of the brain, we found that that was more associated with decline over time. So with these epidemiological studies, we found a decline in function, cognition, quality of life over the long term that's not punctuated by clinical events and not in all cases caused by clinical events. In some cases, as with the HRS studies I showed, this decline emerged even before the event. But in particular, vascular risk factors and vascular events, especially stroke, predicted this decline over and above conditions such as arthritis. And we also saw some associations with inflammatory biomarkers and subclinical brain injury. So let's look at this case for a minute. So this is a 68-year-old male with vascular risk factors, including the ones I was mentioning as associated with decline. This patient had a lacunar left-sided subcortical stroke. And if we mapped his functional status over time, so after recovery from stroke, he came out of rehab, improved, he had a residual right-sided weakness, required a cane to walk, and kind of resumed the same decline as he had before stroke, but 9 months later, he fell at home and required a walker to take a few steps and never really recovered from that point. And 4 months later, had an acute infectious illness and became mostly bedbound, and then kind of persisted along those lines. So this, again, is following this stepwise decline that characterized the sort of traditional understanding of vascular cognitive impairment. But as we saw with the research studies and as we see clinically, this is actually much more common. So a 71-year-old woman, previously independent, with AFib, hypertension, had a cardioembolic parietal stroke on the right side, recovered from that to a certain degree after acute rehab and 3 months of home PT and OT, was ambulatory with a cane, with occasional disorientation to place. But after that point, there was a progressive decline in cognition with impaired attention, executive functioning, and eventually short-term memory loss, as well as progressive gait dysfunction. So where are we now in understanding this? So we demonstrated it not just clinically in individual patients, but also in large population-based studies. But where are we in understanding why this happens and what causes it? So I'm going to go over what we know. Well, first I chose these 5 possible mechanisms based on plausibility and what's already been done in the literature to support these. So I'll speak about each of these in turn and what we understand about them. So first one is ongoing subclinical injury. So the idea behind this is that the reason that there is this ongoing delayed decline after recovery from stroke is that there's actually progression of the number and extent of lesions, even if there are no more discrete clinical stroke events. So these are subclinical events. And there's 3 lesion types. One I mentioned before is subclinical infarcts. The other one I mentioned as well, confluent white matter hyperintensities. And the third that we can measure with MRI is microstructural damage to the white matter tracts. The subclinical infarct, so this is an MRI of the brain showing a chronic infarct, what looks based on MRI findings really to as an infarct. But this patient never really had a clinical stroke event, even on very close history and physical exam. They really don't have any clinical history of this, but it's here. So the question is, how often does this happen where we have this show up on imaging, but really there's no clinical correlate to it? So the prevalence varies, as you can imagine, based on the study and type of study, but most study report a prevalence of 10 to 20% in the elderly and an annual incidence of 2 to 4%. But there's a strong association with age, as you can imagine, and as meta-analyses have shown. Also, subclinical infarcts have been associated with the same things that cause clinical strokes. So the same vascular risk factors: hypertension, cardiovascular, diabetes, etc. So the causes are thought to be the same as clinical stroke, but these are not silent events. And the reason I mentioned that word is that sometimes in literature, these are called silent infarcts, but they do have consequences if you measure them. They have consequences on future vascular events, on gait, functional status, and cognition, as we've seen. So there's a long understanding that particular infarcts or strategic infarcts can lead to particular cognitive syndromes. And I won't get into the details, but if you have particular strokes in certain parts of the brain, there are particular cognitive syndromes that are associated with that. And the idea is also there of a disconnection syndrome, where if you have an infarct in the subcortical brain, you have symptoms referable to that portion of the cortex, even if that portion of the cortex is not directly damaged by the stroke. And the idea behind this is a disconnection syndrome, where the subcortical part of the brain is in the same pathway that projects to the cortex. And so you see on SPECT scan that there's hypoperfusion in that area of the cortex that is not directly damaged by the stroke, but is in the same pathway as the stroke. And there's a good bit of research showing that even the cerebellum, injury to the cerebellum has been associated with the cognitive effects. So the next type of lesion that's been associated, or that can be a candidate for explaining this delayed decline, is white matter disease, also known as leukoariosis. So the pathology of these lesions, so you see this confluent white matter disease on this MRI. And you have some discrete spots here, but the predominance is this sort of confluent, continuous white change on this T2 image on MRI. So when we look at the pathology of these lesions, we see a combination of several pathologies: demyelination, axonal loss, enlarged perivascular spaces, as well as a few others, especially lipohyalinosis and fibrinoid necrosis in the arterioles. This is a very interesting study that maybe sheds some light on how these confluent changes may form over time. So this
Oops, sorry, Dr. Dhamoon. I think we might have a audio. Yeah, there, perfect.
Yeah, can you hear me now?
Yes, perfect.
Okay, I think I was muted for some reason. Yeah, okay, got it. Okay, so this study was performed in only 5 individuals recruited with moderate severe white matter hyperintensity volumes. And these 5 individuals had weekly MRIs over 16 weeks. So it's no surprise they were only able to recruit only 5 individuals. But what they found was very interesting. They found that there are tiny DWI signals. So DWI signals are associated with acute stroke. So they found essentially subclinical ischemic strokes forming that over time then morphed into what we see chronically as this white matter change. So clearly ischemia probably has something to do with these white matter changes, but also demyelination probably has a primary role, as well as loss of trophic elements in the neurovascular unit. And the other important point is that not just ischemic disease, but also dementia has been associated with these white matter changes. The third type of lesion is microstructural damage. So very specific research MRI sequences, diffusion tensor imaging, has been able to show the integrity of white matter tracts in the brain. And these have correlated very well in some cases with functional status. So the idea here is that you may have changes in these tracts over time that are not immediate, but maybe accounting for delayed decline over time. So this very interesting study among 32 patients with stroke performed MRI at the time of stroke and 6 months later. And what they were able to do was recruit patients with subcortical stroke and then identify the portion of the brain above that stroke that was tied in terms of the pathways, in terms of these white matter pathways, to that subcortical stroke. And what they found was that over time, there was a progressive atrophy of those regions of the cortex that were connected to the stroke, but not directly damaged by the stroke. So this atrophy could be another reason why patients have a delayed decline after recovery from stroke. The implications of at least these hypotheses is that perhaps a targeted intensive antiplatelet or stroke secondary preventive regimen may be appropriate for such patients who are at risk of having this accumulation of injury that's subclinical. So there's several studies that are examining this very question. So the Envision study out of Australia is enrolling 600 adults, elderly, with a baseline normal cognitive function and without overt cardiovascular disease, and performing brain MRI and cognitive testing, and randomizing them to aspirin versus placebo to see if these brain MRI measures have improvement. Similarly, with the CEREBRAL study, a similar randomized trial looking at the intervention of 2 years of ACE inhibitors or ARBs, and again, following up MRI in addition to clinical events. So there's a move now towards not just using measurement of events as outcomes, but also using imaging-based outcomes. So that's one possible mechanism. Another one is inflammatory processes. And this was the basis of the inflammatory markers analysis that we did earlier. So there are known to be two stages of inflammatory processes after stroke. There's an acute phase that's potentially destructive and a chronic phase that may be helpful and involved in repair. But it's known that changes in inflammatory profiles have an ongoing deleterious effect on brain structure and function. And animal models have shown that stroke starts an endogenous inflammatory cascade that contributes to ongoing brain damage beyond the ischemic effect. There's some literature from the traumatic brain injury field which shows an accelerated decline in cognitive status after recovery from TBI. And this is even up to 2.5 years post-injury. And it's correlated with expansion of the lesion, atrophy of the brain, and loss of white matter integrity. And inflammatory markers are thought to play an important role in this. So the implications of this are that if it is shown that inflammatory processes have a role in delayed decline after stroke, then targeted anti-inflammatory medications may play a role in mitigating this decline. So natalizumab has been examined as a possible intervention. This is a monoclonal antibody that prevents leukocytes from migrating across the blood-brain barrier. And in a small randomized trial, it was found with up to 90 days of follow-up, there was no effect of natalizumab on infarct volume, but there were effects on cognition and functional status. Similarly for Fingolimod, so this is a medication used for multiple sclerosis that in 2 pilot trials has shown some effects after ischemic stroke and intracerebral hemorrhage on reducing circulating lymphocyte counts, and there have been some trends towards effects on smaller neurological deficits and better recovery. A third possible mechanism involves the blood-brain barrier. So the blood-brain barrier, after stroke, it opens in 2 different phases. So one is more acute, and that's reversible, and one occurs after a slight delay, and it's thought to be that is irreversible. So acutely, we know that blood-brain barrier disruption correlates with hemorrhagic transformation. And chronically, vascular risk factors cause vessel changes and increase permeability, which may actually potentiate inflammatory mechanisms. The implications of this are there are certain medications that target the blood-brain barrier opening. Matrix metalloproteinase inhibitors have been tested in some animal studies, and COX-2 inhibitors as well. And this may play a role if blood-brain barrier disruption is responsible for this. The next mechanism is autoimmune processes. So there have been shown to be oligoclonal bands in the cerebrospinal fluid of some stroke patients. And mouse models have shown that activated B lymphocytes infiltrate infarcted tissue in the weeks after stroke. And that's correlated with the development of cognitive deficits. In mouse models with genetic deficiency and pharmacologic ablation of B lymphocytes, these delayed deficits are prevented, actually. Also in human postmortem tissue, there seems to be a B lymphocyte response to stroke in some people with stroke and dementia. There's been a small study with repeated measures of cognition and measurements of antibody titers, including to myelin basic protein, as well as a few others. And there's cognitive decline that was predicted actually by myelin basic protein antibody titers, supporting this possible hypothesis. So the implication of this is that if autoimmune processes are responsible for delayed decline after stroke, then there are targeted interventions that could help that. For example, rituximab is a monoclonal anti-CD20 antibody that's been approved for several diseases, including rheumatoid arthritis, chronic lymphocytic leukemia, et cetera. And it has been used in multiple sclerosis as well. And the final possible pathologic process I'll mention is that stroke may potentiate a pathology that we see with Alzheimer's disease. So cerebral amyloid angiopathy is associated with the deposition of amyloid in cerebral blood vessels. And this amyloid actually has vascular effects, and it links vascular dysfunction with cognitive decline. Proper blood-brain barrier function includes the ongoing removal of amyloid beta from the brain. So there's a system in the brain called the glymphatic system, which is analogous to the lymphatic system in the peripheral body, where there are convective fluxes of interstitial fluid that clear many extracellular proteins and peptides, including amyloid beta. And it's been shown that the function of this system is altered after brain injury and may result in the aggregation of proteins such as amyloid beta and tau. So the implications of this research, first of all, are that if we focus just on measuring events, the decline that we're seeing, this delayed decline, would be missed. And the burden of the disease, cerebrovascular disease, would be underestimated. So it highlights the importance of patient-centered outcomes, measuring these, analyzing not only single time points, but also trajectories over time, and focusing on well-measured epidemiologic data. So it also highlights the importance of subclinical disease, but we still need to better understand the factors that influence this decline. And I mentioned 5 possible mechanisms, but what is the next step? And luckily, I'm able to say something about that. So just in the last few minutes, I'll speak about 2 studies that are ongoing that are actually targeting these very questions. So one is the Determinants of Dementia After Stroke. This is a study in Germany, an observational perspective study in patients with acute stroke and no prior dementia. They're performing multimodal imaging to try to tease out what the mechanisms are of this delayed decline after recovery from stroke. And they have 5 years of follow-up, so they should be able to get to some of these questions. And even more importantly, here locally in the US, the NIH put out a proposal a few years ago for a U19 study, a multi-center study. And what they recognized was that despite the established relationships among stroke, Alzheimer's disease, and dementia, there's so much that's not known. The specific types and magnitudes of stroke events that cause cognitive impairment are almost entirely unknown, as are the specifics of comorbid clinical factors that may synergize with stroke to cause cognitive decline. So luckily, the NIH invested a significant amount of money to try to solve these problems. And they just, actually over the last 2 years, the Discovery study was funded. So this is a large multi-center study. Mount Sinai is a participant in this. I'm the local site PI for this study, and we're just getting off the ground now. But this is a prospective multi-center observational nested cohort study among 8,000 patients, proposed 8,000 patients, not just with ischemic stroke, but also intracerebral hemorrhage and subarachnoid hemorrhage. And the goal is to include analysis of imaging characteristics, inflammatory biomarkers, vascular risk factors, and even social determinants, correlates with AD biomarkers and outcomes, up to 4 years of follow-up. So we're just getting off the ground. Nationally, they've just started recruiting. So in a few years, hopefully we'll have a greater understanding of the patterns and determinants of post-stroke cognitive and functional decline. And we may even be able to develop imaging and blood-based biomarkers to predict this decline and then hopefully develop treatments to halt and prevent post-stroke decline beyond the acute recovery period. I just wanted to acknowledge the NOMAS study and my collaborators at NOMAS, SPS3, and the Cardiovascular Health Study. Thank you for your time.
Great, thank you, Mandip. That was terrific. We already have a couple questions in the chat.
Okay. Let me put the chat here. Okay, right. Should I read the first one out?
Yeah, you want to read them?
Yeah, sure. At Einstein, they have been following a different population to look at aging. Yes, the Einstein aging study. And they measure cognitive and physical function, and they look at the genome. Do you do any genetic studies? I personally don't. Genetic analysis will be a part of discovery. It's being run out of Boston, so I don't know which center is actually running that. And we're still very early in recruitment, so I'm not sure what the plans are for that. But yes, they will be looking at genetic aspects of that as well. The next question, the Barthel only measures basic ADLs, correct? Regarding executive functioning in the office assessment, how much do you rely on IADLs? And what mental status exam do you use to diagnose executive functioning loss? That's a great question. I think the pressure in the clinic is time. So you have to be very focused. So on all my stroke patients, I may not measure cognitive status. It's only in those who are complaining of some decline or in whom I have an interest in doing that. Just, practically it's just a time question, really. So the MoCA, the Montreal Cognitive Assessment, is one that's been accepted pretty well in the stroke literature. Specifically for executive functioning, we do use IADL scales such as the CAT scale. I don't know what the literature would recommend specifically for executive functioning, but those are some of the things we use in clinical practice. I think those are the only two chats I'm seeing there.
So far, yeah. There's one just came in now.
Okay. To what extent do you think social determinants of health besides race or ethnicity serve as correlates for decline? Is the decline same in poor whites? I think social determinants play a huge role in functional status and cognitive status. And there's a large literature on reserve, so cognitive reserve, and its corollary is functional reserve. And social determinants, education, socioeconomic status, early life experiences have a huge role in that sort of reserve or that baseline. I think the problem has been that it's just very hard to study this. You need a very large sample size. You need very good measures, and the Discovery study luckily is examining some of these social determinants. So hopefully in a few years we'll have some more answers. The next question that came up: any evidence that cognitive training is of any benefit in cognitive impairment associated with strokes? Yes, I believe so. I can't quote studies directly, but clinically, yes, we refer our patients to neuropsychological evaluations for this kind of cognitive impairment and decline. And the interventions that they in my experience, have been quite effective. In terms of research studies, exactly proving different modalities of cognitive training, I don't know of that offhand. But clinically, yes, we do use that.
We'll take one more question, okay, Mandip?
Yeah, sure.
What have been
the criteria to select immune modulatory therapies? Are there biomarkers that have been used in selecting patients for these early trials? So in the ones that I mentioned, I believe actually no, that biomarkers were not used. They were very small, essentially pilot studies. And they selected just based on the clinical presentation and I believe in some of them lack of prior cognitive impairment. But I think for larger studies, so for example, so Discovery is looking at a large panel of biomarkers, and hopefully we'll be able to see if we can select patients based on that.
Great. Dr. Dhamoon, thank you very much for today. It was great to have you bring your expertise to our department. It was a really great presentation. So thank you very much for coming. And
Thank
thanks
you. I appreciate
everyone.
it.
Yeah, absolutely. Have a great day, everyone. Take it easy.